Hi, I'm Dr. Matt Brengman, and I'm going to talk to you a little bit about where is the intersection between obesity and orthopedic diseases. So we've seen a change in the market and in the care of people who have combined obesity and significant joint disease. Over the past 2 to 3 years, there's been a lot of published scientific literature on risk of having a joint replacement, knee or hip, at the same time as somebody is significantly overweight. And when we say significantly overweight, we're talking about obesity, 75 to 100 pounds overweight. There's two major problems with doing a joint replacement in somebody who's 75 to 100 pounds overweight or more. First is risk of having the operation. So the risk of having the operation with early complications and early infections is much higher in the obese population. And then there's the durability of the implant. These implants are really intended to be 15, 20-year implants, and we see that number coming down to 10 years or even less because of the extra weight that's put on the implant. It's not designed to hold the kind of forces that are at play in somebody who's significantly overweight. Because the data has become clearer, we've seen recommendations from orthopedic surgeons for people who have a body mass index over 40, which is typically 100 pounds overweight, to lose weight prior to their operation. Some of those people might need surgery. Some of those people can do it with medicines. Many of those people can do it through dietary interventions alone. So when we look at employing different therapies for weight loss in patients for a targeted weight loss goal. So for instance, you need to have your hip replaced, or you need to have your knee replaced, or you need to get a kidney transplant, or you need some other therapy where there's a weight target identified. That's different than the person who wakes up on January 1st and says, I think I need to lose 20 pounds, right? These are specific numbers, and we can relate the amount of weight they need to lose to their current weight, and we can compare that to the effectiveness of the types of therapies that we have. This is not different than when you go to the doctor and you have high blood pressure. So you have high blood pressure, your blood pressure's a certain amount over normal, you get a medicine, it gets rechecked, and if one medicine isn't enough or isn't strong enough, you get a different medicine to reach the goal of a normal blood pressure. So we can think of weight management the same way when we're looking at targeted therapy like this. So what are the broad categories then? So we know that a dietary intervention, a good dietary intervention with a behavioral component, I'm going to eat less, I'm going to eat certain times per day, an activity component, I'm going to go to the gym or I'm going to walk, and maybe a support component with a psychologist, in scientific studies is good for about 5% body weight loss. If your body mass index is 40 or 42 or 43, pretty reliably you could get under 40 with that kind of intervention. That's good. If it's 50, probably that's not going to work. 5% isn't enough to get you to 40. But it's always worth trying. The important thing about a dietary intervention when we're talking about a spectrum of weight and a spectrum of therapies is that unlike the high blood pressure, where if your pill's not working, you go back to your doctor, they just give you another pill. In weight management, you have to meet certain requirements to get different therapies. And the majority of those requirements center around an organized diet that's been well tracked. And so if you enter into a medical weight loss regimen for targeted therapy, you want to be sure it meets the criteria for the next step if that becomes necessary. Because the last thing you want to do is put all the effort to go through a diet and make lifestyle changes for 4 or 6 months and at the end, not be eligible for the next therapy because it wasn't done correctly. So it's really important that we get that box checked, that your insurance requirements are known, and that whatever diet you embark upon meets your goals. So let's say your weight is higher than 5% above your target, or you've done a medical weight loss therapy and it hasn't been effective enough to get you to your goal. The next step would be medications or even a endoscopic procedure like a gastric balloon. Those therapies are going to be good for about up to 10% weight loss. So again, that's sort of somebody with a BMI of maybe 45 or 46, getting down to a BMI of 40. So if you're in that range, that's a good therapy for you. Again, it should be well tracked. It should be done by a professional, somebody who's experienced with the therapy, that's going to do the appropriate lab testing if that's required, and can document your success so that you can get ultimately why you started losing weight in the first place, whether it's going to be a knee replacement or a hip replacement or even a transplant. For people who have a BMI of 50 or more, there's really no data in the dietary literature to suggest they're going to be able to lose weight down to a BMI of 40. It can happen, right? As with every therapy, there are outliers, the 1 in 100 or 1 in 1,000 that can lose weight, lose 100 pounds. But those are really unusual people. But BMI around 50, we should be thinking about surgery because that's the therapy that works for that group. Now, those people will also have a dietary requirement. And so it's important that when they start a diet, they are really aware of what the requirements are. Because at the end of their 6 months or 4 months or whatever it might be, we want to be sure that they don't have to repeat it. Because that doesn't serve anybody well. It doesn't serve the patient or the physicians because it just delays care. And there's some evidence to suggest that a delay in care causes more problems. So when we approach therapies, there's a broad spectrum. We have a broad spectrum of patients. We want to match the patients to the right therapy, but we want to do excellent documentation of what we've done so that everybody's eligible for the therapy they need.